So next up we have Hannah and Nicholas, and they're doing Better Together, Elevating Physical Health in the Mental Health Care System. Hannah's a registered nurse with over 10 years experience in mental health across diverse clinical settings and currently a nurse consultant in the Safety and Quality team at the Office of the Chief Psychiatrist. And Nicholas is discipline in lead for nursing and lead in Uni SA Mental Health Suicide Prevention Research and Education Group. So welcome.
Okay. Thank you for having us both here today, and it's really lovely to follow on from Sarah and Dr. Bass as well. I think their presentation actually really complements ours quite nicely. I'm not related to the Prime Minister. That would be great if I was, because I think I'd have solved all of our problems, because I could have just said to him, hey, let's fix this. But unfortunately I can't. So I guess Nicholas and I are here today to talk about the development of a Chief Psychiatrist standard for physical health care within South Australian mental health services. I'd like to say that we've done it, we've published it, we've implemented it within our mental health services, but unfortunately that hasn't happened just yet. We're not far away, we're almost there. But I will just skip over our acknowledgements. Unfortunately, I understand that we're probably really pressed for time. So, John's going to hate me. But just a bit of background, I guess, for the people in the room that aren't from South Australia and don't understand what the functions and the role of our office is. Dr. Brayley is our current Chief Psychiatrist, and as Chief Psychiatrist, he holds he's a statutory officer who holds powers, functions and responsibilities prescribed by the current Mental Health Act. And these statutory functions allow John as the Chief Psychiatrist and us as members of his team and his office to support the state in our services to provide care that ensures the rights of those with a lived experience of mental illness are respected and safeguarded in the care that we provide. Got to do multitasking up here. I won't go through all of this, but a bit of background and understanding of what the Chief Psychiatrist functions are. You guys can read them there. Yep. But essentially, John's responsible for monitoring the treatment and voluntary of people receiving care and of restrictive practices, and also of monitoring the administration of the Act and the standard of mental health care that we provide here in South Australia, and through that, issuing and binding standards that are to be observed in the care of treatment of patients here in South Australia. And so that's where this standard fits into the functions of what we do. I guess I'll also add in as well, because it's linked in, is the role of our inspections team within our office. So another function is the authority to conduct inspections of services. And so really, when we do go and conduct these inspections on our services, we look at the standards that we've issued within our office as well to ensure that the care that is being provided is meeting that as well. So just a bit of background, you'll probably hear it in other presentations. By no means are we absolutely kicking goals in physical health care, in mental health in South Australia. I think, we're all, the clinicians at the front line and within services are really trying their best. There's a number of challenges that we're facing, but we do have a history of having tried to work at addressing the physical health disparity and concerns that we see within our mental health lived experience community. Back in between 2007 and 2009, there was a core group of clinicians that worked to develop an action plan called It's Not Just About Your Head. Lisa Wilton, who has been mentioned before and is presenting multiple times throughout this conference, was a part of that action plan and that campaign that was launched in 2009, and that remains active to this day, that there's ongoing web pages and resources available targeted at people with a lived experience, but also targeted at clinicians as well around physical health, especially that metabolic health care. There's been statewide training programs as well that have been developed for medical and nursing staff that were developed utilising the Northwestern Adelaide Health Study, biomedical measurement technique which looked at training staff in how to conduct metabolic monitoring and physical health assessments, and those trainings remain ongoing in our services today. There's lead trainers available within the LHNs that are supporting clinicians to have that training to provide those healthcare physical health assessments to staff. Back in 2013, there was nurse practitioner roles, and there was a period that were within our metro LHNs. There's a period of time due to funding and people retiring where those positions weren't replaced, but we have the likes of people like Sarah Skinner and other nurse practitioners within our LHNs like Carmen, and I think there's another one in Narlan as well, Janine, who are back involved in those roles and targeting care, have scopes and projects and a focus on physical health care and equally wells, which is fantastic to see. There's been lots of initiatives that have happened and pilot programs over the years as well that have been looking at addressing physical health within our mental health services community, acute inpatients. Again, funding, resources, unfortunately, have not allowed those to continue, but I think, you know, it's evident that the staff on the ground and in the services know that this is something we need to do and are looking at ways to do it. And there's also historically been large investments in physical health monitoring equipment as a part of that. We have documents within our multiple clinical systems that we use, CBES, CCC, Sunrise, EMR, for example, here in South Australia, which obviously makes communication between services really challenging, but our systems do have screens that are available for staff to, you know, document our physical health assessments of our consumers that we're providing care for. So recently, last year, our physical health screens got a big overhaul and a revamp. They're lengthy, like 7 pages long of screens, but they're now targeting components around preventative health checks, which are, you know, looking at when people have had encouraging that discussion with consumers and when they're next. These are not an actual person's records, these are just from our test systems, but, you know, and it will have a record there of staff that have been involved in following up, who's responsible for following up. So clinicians and services know who is in charge of that and who's responsible in supporting that consumer in that aspect of their care. Keeping a record around physical comorbidity conditions so that staff are aware when they maybe don't know somebody, are coming across this person for the first time in their service, can have a clear representation, a clear picture of what this person's physical health situation is at that time. And if there isn't one, it's giving them a guideline of what they can do to assess and get this information to provide that record for the next person coming in. We've also looked at including and have included the SNAP lifestyle factors as well in there.
Yeah, so some things that are challenges along the way, and these are probably things that resonate with other settings and contexts as well. The whole idea about siloing, particularly of the health system, how can we create something that might bring people together a lot more? So the siloing of mental health services and general health services, funding resources, disparity across different local health networks. So in South Australia, there are 11 local health networks, 4 in the metropolitan, 6 in the regional areas. Trying to get some consensus, knowing that they're geographically different and have different needs and different population groups in some instances. And I guess the big story here is in thinking about these challenges, how can we work towards something that's a shared model? It's a statewide, state-owned and state-embedded model for practice to address these challenges and certainly some of the things that Hannah's already spoken about and other speakers have. So the Equally Well Working Group became the statewide really vehicle to be able to drive and bring together some of these things. And that got going back in June 2024. Initially meeting monthly, but now meeting bi-monthly. And the good thing about this group, and I belong to this group, the great thing that I notice when I'm at a meeting and when I'm talking to people afterwards is it's a coming together of all of that thinking, lived and living experience, First Nation, culturally, linguistically diverse background, physical health practitioners, general practice, people from different disciplines in public health. And some non-mental health clinicians as well, so pharmacy, and other areas. Dental is becoming a real feature, the most recent meeting in particular, exercise physiology, dietitians. And the important purpose of the group is to promote best practice by improving not just the topic of physical health care, but the exchange of information about physical health care. And the group have also initiated a communities of practice, a statewide communities of practice, where people who don't necessarily work alongside each other every day, they come together because they find value and meaning in their interactions, and there's over 50 people who are involved at various time points in that community of practice. So it really sets the scene for the Chief Psychiatrist Standard. So I guess these introductory slides are really setting out not just the landscape, but what were the tasks that were driving the development of the standard. And there's some great people who have all come together, and again, Lisa Wilton, who many people will know. Camillo, who is not with us today, was an instrumental person in the development of the standard. He's since left the office of the Chief Psychiatrist, but important to acknowledge his contribution as well. So let's go more deeply into developing the standard. I'll hand back to Hannah. Thanks.
So, taking all of that into consideration, developing the standard for us, that group came together from the working group, and initially it was really about determining what we needed to include into the standard, considering a number of factors. So we really identified that the standard needed to be grounded in, obviously, the principles of the RANZCP and the Equally Well consensus statement. That was what we were here to sort of address, because, it's understanding that our consumers are at this absolute, unfair and disadvantage when they don't deserve to be. Everybody deserves the right to equal health care. And so about how can we change this for them within our services. It was about ensuring promotion of this equitable access to physical health care, and that collaborative care and improved wellbeing for those with a lived experience of mental health was paramount to the standard. And about identifying that the content needed to ensure that their rights were upheld while also delivering improvement to physical health care collaboratively within mental health services. And that determination of expectations and mandatory functions of the standard. How can we measure these and ensure that the standard's being complied with, like I mentioned, when we go on our inspections, but how can we as a statutory office check in with services to ensure and have that oversight that what we've written and the services are able to, comply with the expectations of the standard within our gazetted mental health services. I think as well, we've got a number of other standards that our office has produced, and this one, and a lot of them are, have findings related to the legislation of the Mental Health Act, and that kind of, really supplement and support that. But this standard, along with a couple of others that we've written, are really about a quality improvement component too, and it's really about addressing an issue within our healthcare services and how can we basically better improve our outcomes from that quality improvement perspective. So the document is very long at the minute. For those that have seen it in consultation processes, are aware that it's quite a number of pages with a lot of points to it. So this is just a bit of an overall summary of each of these sections of the standard. But having a look at expectations, and I will make a note as well that these are based on our original version that we popped out for consultation. Obviously, it's a work in progress at the moment, and probably bits have changed, and it will continue to go out for further consultation once we've finalised it. But key themes are within the expectations of mental health services, equal access, so that all people accessing mental health services have the right to physical and dental health care equal to those of the general population. That care is integrated, so that mental and physical health care is coordinated with equal priority to support that person's recovery. That it's a collaborative approach. Mental health services and GPs engage in that bi-directional partnership for shared care, which reflects that bi-directional relationship that we talk about of mental health and physical health impacting one another, and it challenges that challenge that we face of this siloed approach to our services. Person-centred and culturally safe care. This is a really strong theme that we've really ensured is highlighted throughout our standard as well, ensuring that care is holistic, it's trauma-informed, it's culturally sensitive, respecting Aboriginal, First Nations people, cold communities, and addressing language barriers. So that ties into, we've talked about it a lot today around health literacy, and lots of our dot points talk around ensuring that information that we're providing to our consumers is available in formats that's able to be understood by them, whether it's the language level, whether it's the language that it's provided with, that it's adaptable and it's provided in a way that meets their needs, and is culturally safe and trauma-informed. That participation is informed by the people that we're providing care with, not to, we're providing it with them. That people, their families, carers, supporters of choice receive clear, accessible information to make informed decisions supported by services to do that. But ultimately, we're working with them for them to make those decisions, not directing that care. And that ongoing monitoring and referrals occur, that physical health, including dental, is regularly assessed, and referrals to GPs or specialists occur as needed with that person's consent and as required within legal requirements, and taking into consideration that we're referring to services that are appropriate as around age demographics and their needs there. Looking at requirements. So these start to become a bit like the mandatory elements that I talked about being measurable. So again, it's around that clinical collaboration, mental health services, GPs working collaboratively to ensure that physical health assessments, chronic condition management, using that shared care approach that's been talked about in other presentations here today. Standardised screening, implementing routine physical and metabolic health screenings like those screens that I had up before, with referrals to GPs for ongoing care as required. Timely assessments. This will probably change in the updated standard with the feedback that we've had around what's able to be achieved within services. But I think these assessments these are not extravagant assessments. These are really those initial nursing physical health assessments and then those medical assessments that are happening by our medical officers that then inform our practice and our care referrals or engagement with the person around what care is needed next for them in their physical health journey alongside their mental health care. Having clear protocols, so all the LHNs having, I guess, established documented processes for assessments, screenings and escalation of abnormal results. So a process that staff can actually follow and know what they need to do with the information that they receive from the assessments that they're doing. Education and communication. Staff being trained on physical health conditions, medication side effects, improving compassionate and providing compassionate, clear information to people and their families and carers. But I think that also goes to that staff are actually supported to be educated in this as well, which I think is really vital and important. I speak as a nurse here who has, got a long history of, sadly, when there's demands of a service, education does get pushed to the wayside, but that's what drives our practice and our improved care and that we give to our consumers. If we're not up to date, we can't provide the best care. So having staff supported to be able to engage in that education is really important. And individualised care plans for our consumers that meet their physical health needs alongside their mental health care needs as well, being addressed not just in our mental health care plans, but also in other care plans that are available within services. On to you.
Okay, I've got the signal that we're running a bit short of time, but I wanted to say that, this you're already emerging, I hope, is the multi-layered dimension of this. So I'll be very brief here. Just really the thinking about, let me see if I've got this right. The really thinking about diagnostic overshadowing, again, preventative and promotive health actions and healthcare, addressing coexisting or comorbidities, those sorts of things, they are really embedded. And so that multi-layered dimension, I'm going to go back to Hannah, we're short of time, but just really acknowledging that, advocating for vaccinations, metabolic, physical health of sex, addressing comorbidities, holistic and culturally sensitive care. So thanks, Heather.
So implementing it, again, it's that partnership in care, that collaborative approach with services and the consumer and their families, carers, supporters of choice to plan, set goals, make informed decisions through all of that we've talked about before. But also working, like I said, working with GPs, but working with physical healthcare services within the LHNs, tapping into those other resources that we're able to. It's looking at integrated communications. We talked about in the workshop before that we'd love this like single system that everyone across the whole country could all link into, and that's just the dream, but I think we're a little way off of that. But that assessments include communications with our GPs and our specialists. It's not just we've done the assessment, you've done your assessment, and none of us communicate and talk. That doesn't put the consumer at the centre of their care. It just meets our needs, but we're not actually benefiting them. There's no point doing the assessment if we're not going to share those results with people and for the benefit of the person that that care is for. Again, that shared care model, the support for unengaged individuals. So for people that aren't already engaged with a GP provider or a primary care provider, around mental health services, providing that until they're able to engage and share that care and the ongoing care provision. And respect for choice and documentation. So people have a right to decline the physical health care, and that's okay, but it's about working with that person to understand why it is that they might not want to engage in the physical health session. It might be at that point in time they're just not ready to address it. We've talked about that earlier. But it might be that with a bit of conversation, a bit of education that meets their needs, that in 2 weeks' time in the community, and when you catch up with them again, that they're ready to start just having more conversations about it. They might not be ready for that assessment, but having those conversations with them to start unpacking it and documenting why we're not able to sort of achieve that at this point in time and what we're doing as a service to address that moving forward. So we've done a bit of a consultation process on that initial one. There's really many people in the room here that have probably provided feedback on it, but we put that out to our lived experience representation, to our Equally Well working group, out to our LHNs, to our GPs that are involved or employed within an SA Health liaison role, primary health networks, were all able to provide feedback, and we got a lot, actually an overwhelming a lot, which is a good thing, because I think it means that, you know, we're all on the page. You can see that everybody in these rooms here are sharing the same vision, but we all understand that we work in systems that are challenged, and how can we do what we're asking, because I think we all want to do this, what we're kind of asking and setting in the standard as clinicians. We all want to do this, but we know that it's hard, and how can we do it? So we got a lot of feedback provided to us, and different ideas about what the document should contain, what's achievable within the service, and really highlighting as well the disparity across mental health services within our regions versus metropolitanly, which we know is really significant. So it's really it's been great for us to really take all of that feedback on board and refine it to make it a document that services our consumers how it should, but also takes the needs of our services into consideration as well around what they can achieve to provide that care that we're wanting to provide. So we are working through that. Nicholas, Lisa and I keep meeting regularly, and every time we do, we keep finding more bits that we need to adjust and change. So I promise it's coming, hopefully by the end of the year, if not early next year. So our next steps are to finalise the feedback and the standard itself, put another round of consultation out, much broader consultation this time, finalise that standard and get it publicised out there across our SA Health network, and implement that standard within our mental health services, letting, you know, with a process of a time where they've got to have the requirements or the expectations in place for them to be able to meet that. Monitoring of the compliance and those measurable expectations will be ongoing throughout our inspections program, and also reviewing the standard over time as the services change and the needs. And we'll develop a guideline, but that's the next step. We've got to get over this bit first. That's it. Thank you.